नमस्ते बेटा, खुश रहिए आप लोग। आई माई सेल्फ जीवन प्रतिष्ठा राजवंशी, वर्किंग एज एन असिस्टेंट प्रोफेसर इन यूनिवर्सिटी in the Department of Faculty of Physiotherapy and Diagnostic. I am working in Jyoti Vidyapeeth Women's University. It is the first university state women's university in Rajasthan. So in the last lecture which I have uploaded, we have discussed about the this anterior chamber. What is anterior chamber? What are its part, and many more things. Now today we will discuss about the leftover topic of the anterior chamber and its function. So now we are going to start our topic. Okay. Now what is anterior chamber? You already have read in last lecture. One more time I will be telling is anterior chamber and the anterior drainage and these all. Index anterior chamber. Angle of anterior chamber is the angular space and it is bounded anteriorly by the posterior surface of the cornea, posteriorly by the lens thinning the pupillary aperture, anterior surface of the iris and part of ciliary body. Anterior chamber is 3 mm deep and it contains 0.25 ml. We have also studied about the chamber depth, slightly diminished or decreases by 0.01 mm per year of life. Chamber deepens by 0.06 mm for each diopter of myopia. Then today now we are discussing the meshwork. So we have discussed about the ultrastructure of meshworks. Now another is left, that is the trabecular endothelial cells. That is the larger, more irregular and have less prominent borders than corneal endothelium. It is joined by gap junction and desmosomes which provide stability. Two types of microfilaments are actin filaments, that are cell periphery around nucleus in cytoplasmic processes. Cell contraction, phagocytosis, pinocytosis and cell adhesions, regulating the shape and cytoskeletal organizations. Now second one is the intermediate filaments. These are numerous in number, composed of vitamin and desmin, imparts the contractile and mutability function. Now what is the juxtacanalicular tissue? The outer portion of the meshwork is adjacent to the Schlemm's canal. This structure has 3 layers consisting of a layer of connective tissue lined on either side of the endothelium. The inner trabecular endothelial layer is continuous with the endothelium of the corneoscleral meshwork. Now the central connective tissue layer has variable thickness and is unfenestrated with several layers of connective tissue ground substance. The outermost portion of the trabecular meshwork is the inner wall endothelium of Schlemm's canal. This endothelial layer of significant morphologic characteristics which distinguish it from the rest of the endothelium in both the trabecular meshwork and in Schlemm's canal. So what is Schlemm's canal? This 360-degree endothelial lined channel. It is a single channel but occasionally branches into a plexus-like system. The endothelium of the outer wall is a single cell layer and that is continuous with the inner wall endothelium but has a smooth surface with larger, less numerous cells and non-porous. The outer wall also differs in having numerous large outlet channels. Now, lip-like thickenings are present around the openings of the outlet channels, and septa are noted to extend from these openings to the inner wall of the Schlemm's canal, which helped keep the canal open. Then, what collector channels? When the protection is having for the aqueous humor, then there should be the collective channels also. Schlemm's canal is connected to episcleral and conjunctival veins by the complex system of intrascleral channels. Two systems of intrascleral channels have been identified: an indirect system of numerous finer channels from an intrascleral plexus before eventually draining into the episcleral venous system, and a direct system of large caliber vessels which run a short intrascleral course and drain directly into the episcleral venous system. They are about 6 to 8 in number and also called as aqueous vein. Since these aqueous vessels terminates into the episcleral and conjunctival vein in laminated vein of Goldman. Episcleral and conjunctival veins. These veins join the aqueous vessels by the several routes. Most aqueous vessels are directed posteriorly, with most of these draining into episcleral veins, whereas few cross the subconjunctival tissue and drain into conjunctival veins. The episcleral veins drain into the cavernous sinus by the anterior ciliary and superior ophthalmic veins, while the conjunctival veins drain into superior ophthalmic or facial veins by the palpebral and angular veins. Innervation of outflow apparatus derives from the supraciliary nerves plexus and the ciliary plexus in the region of scleral spur. Both sympathetic adrenergic and parasympathetic and sensory innervation present. Nerve endings contain mechanoreceptors which are located in scleral spur, which acts as a proprioceptive tendon organs for the ciliary muscles, whose longitudinal fibers insert into scleral spur. Contraction microfibroblast scleral spur cells. The third one is the baroreceptor function in response to change in IOP. These are the innervations of outflow apparatus. Now, what we'll be doing to study is that the assessment of anterior chamber, how the anterior chamber is assessed. Okay, now indications of assessment: glaucoma suspect. In glaucoma suspect, open angle glaucoma, ocular hypertension, angle closure glaucoma, retinal vein occlusion, blunt trauma. Okay, what are the method? Oblique flashlight test, vein Herrick technique, and gonioscopy. Okay, now what is the advantages? Simple, it is simple and no sophisticated equipment required. Okay, limitations: that lack of standardization and arbitrary cutoffs. Then what are the advantages of these limbal gonioscopy? What is the advantages? Then it is quick, non-invasive, non-auxiliary equipment. And limitation: it is subjective, horizontal quadrants only, affected by corneal degeneration such as arcus senile, little or no information regarding angle morphology, overestimation of angle depth. Gonioscopy is indirect. In two types: indirect gonioscopy, most common, reference standard grading of anterior chamber angle, depth, iris configuration. Then advantages: easily and commonly performed, not expensive. What are the limitations? Invasive, subjective, requires skill and experience, does not provide quantitative evaluation of the angle, cannot visualize structures, procedure to iris. Objective measures are ultrasound microscopy, anterior segment optical coherence tomography. Then two-dimensional high resolution grayscale images of ocular structure, anterior to pars plana, quantitative and qualitative evaluation, principle similar to that of the B scan. Frequency 50 MHz, more frequency, less penetration and more resolution. Then open angle, angle opening distance, length of perpendicular from trabecular measurement to iris at a point 500 micrometer from Schlem's canal, scleral spur. Then trabecular iris angle, apex in the iris sulcus and arms passing through the point 500 micrometer from scleral spur and the point perpendicularly opposite on the iris. Okay, so that's all about the anterior chamber. You should study both the lectures carefully, and if any query, then comment in comment box. I will be resolve your query, and till that, have a nice day, have a nice time, stay at home, stay safe. Thank you everyone. Khush rahiye.